We're going to finish the course with a discussion of the treatment of psychological disorders. The term psychotherapy applies to um, any kind of psychological intervention. And psychotherapy interventions are designed to resolve individuals' problems and improve their quality of life. And that is a very broad definition. Usually, when people think of psychotherapy, they're thinking of a traditional situation with a provider of some sort, probably a doctor, and a patient. Um, but really, psychological interventions, this definition is much wider than that and could include many, many different situations, including school guidance counseling, or a school psychologist, or a high school student working with a social worker. Anytime a professional individual works with an individual to resolve their problems, improve their quality of life, could be called a psychological intervention or a psychotherapy. Generally, these kinds of things are assessed with science to see if they're effective or not, but not always. By some accounts, there are at least 500 types of psychotherapies. Not all of these have been met with research demonstrating their effectiveness, and many have persisted even though there is no evidence for them, or the evidence is even against the psychotherapy. I believe at one point in the course I told you about rebirthing therapy. Rebirthing therapy is a psychotherapy because it was an intervention designed to resolve individuals' problems and improve their quality of life. Rebirthing therapy is based upon the assumption, and every therapy has some kind of core belief or assumption, that in this case, rebirthing therapy believed, excuse me, that individuals' problems in life, be they depression or anxiety or inability to form good relationships with others, stress from the trauma of being born, kind of the initial trauma. Now, underlying this is the recognition that traumatic events for individuals usually lead to depression and anxiety. So, rebirthing therapy was designed to relieve the trauma from the initial traumatic situation they believed everyone went through. So rebirthing therapists would set up a situation with an individual by which they would physically relive the situation of birth. Often this involved climbing into some small enclosed place and kind of wiggling their way out while receiving some kind of encouragement and support. And the view was, by confronting the trauma of birth in a positive way, that it would alleviate the stress and depression that they're experiencing as an adult. Rebirthing therapy has no evidence for it, even though there is this quote unquote logic behind it. There's no evidence for it, and it is even proved to be harmful and has led to the death of at least one individual. There was a girl, I think she was about 10 years old, whose parents took her to a rebirthing therapist. They rolled her up tightly in a carpet, and she was unable to wiggle out, and suffocated as a result of this misguided therapy. So there's 500 types of therapy, psychotherapies. All kinds of individuals are out there doing them. There's herbal therapies. There's life coaches. Many of these individuals are not licensed by the state. They may or may not have sufficient training, and there is not usually evidence in favor of most of them. The ones that we're going to talk about in this chapter are the ones that have established histories, have record of success at treating disorders, and are the general types of therapies in which psychologists would provide. Before we get into the kinds of therapies, I want to talk some about who seeks and benefits from these therapies. In terms of statistics, it seems actually very few people who would benefit from a therapy actually seek it out. Uh, Surveys tell us only about 20% of Americans with a disorder in the last year have received treatment. So, when we say with a disorder, we're talking about something from the last chapter, something that would be diagnosable according to the DSM. So, there's many, many more people out there who could benefit from therapy but are not seeking it for whatever reason or another. The statistics on people who go to therapy show us that women tend to seek out therapy more than men, and Caucasians and white individuals seek out therapy more than minority groups. This is just seeking out. This is nothing about the success of the therapy. So there's many barriers to therapy. And one of the things I like about your textbook is it talks about these. It confronts that the question of why not everyone who has a disorder seeks treatment. And there's a lot of different reasons for that. Some of the most prominent are not necessarily so obvious. Often people may not realize that their disorder needs to be treated. And think about this. I think about this with myself. If I have a cold or I have allergies, so if I get sinus infections, and I can kind of recognize when they come on, but I'll often be resistant to go to the doctor to get the medications I need to help me out because it's inconvenient, or I don't want to, or I was just there last month, I don't want to do it, but it's easy to put something off. And that makes the condition kind of get worse. So I usually wait till I can't stand it anymore, and then go seek treatment. And I think that's the same with psychological disorders. People may not realize that their disorder can be treated or should be treated. And sometimes they may not even recognize that they kind of have a disorder. So this kind of lack of realization that they need treatment is part of it. Another part is that individuals have beliefs and circumstances that keep them from getting help. There might be religious beliefs that don't put things in the hands of man rather than put them in the hands of some higher power. There certainly is in our country lack of belief in science and the belief that experts really know what they're doing, so that can keep someone from going to see a doctor. They don't believe in disorders. They don't believe in treatments. Monetary, financial circumstances might keep people from getting help. Therapy is expensive. There's certainly plenty of people in this country who don't get medical help because they lack insurance, and the insurance picture is even worse for mental health services. So financial reasons may keep people from getting help, as well as geographical circumstances may keep people from getting help. We live in Connecticut. We're blessed with many resources for all kinds of things, and if you drive down any major street or downtown area in any one of our cities or villages, you're likely to see a doctor's office or a therapist's office. You look around and you'll see them. It might be an office building, but there'll be one little sign on it that'll say something like Jane Smith, LCSW, psychotherapist. These things are inner community and they're easily accessible. That may not be the case with people who live in Maine, or people who live in Kansas, or people who live in Texas, where the population is a lot thinner. There's not this level of service in every part of our country. And someone may have to drive an hour and a half to see a psychotherapist. So that can prevent them from getting help. Another dilemma is that people may not know where to look for services. Who do you go to if you need help? And this is a question I usually ask my class. If you're a college student, you're on campus, and you know your friend is suffering from a lot of anxiety and maybe even a little bit of depression, where do you go to get help for that person? Where would you go? You're probably thinking the doctor or the RA. The RA is good. Health services are good. That's a good place to start. But on the second floor of Engelman Hall is a counseling services center. Southern maintains, most universities do, a psychological counseling center that is devoted to providing free, if not low cost, if not free services to students while they're enrolled, because they recognize that helping people with stress and anxiety and depression uh, can facilitate their academic performance. So one thing you might have to do is ask, and that can be kind of the hard part. But at any university, there's always a counseling services. The other thing to consider is that often when people do look for help, they sometimes do not receive the most effective treatments. Sometimes they go by word of mouth, and end up receiving a treatment that has not been supported by research. There's some evidence that at least 1/3 of people report receiving treatment that has been supported by research. That means 2/3 don't. Um, so it could be the case that someone's suffering from depression or mild anxiety, and they hear that their friend says, "Oh, I had that, and I did the juice cleanse, and I felt so much better after that." They go by anecdote rather than science. They listen to friends or neighbors who had success with crystals or essential oils, rather than seeking out an expert and having the problem diagnosed fully. The other thing about treatments is who provides them. So there's services available. Most people who need them probably don't get them, but part of that reason isn't because there's a lack of people who are trained to provide them. There's plenty of folks who provide treatment, and many of you listening to this lecture are probably in this class because at some level you want to help people. What I'd like to talk about in this section is the kinds of careers and individuals that do provide psychotherapies and how they're different. As a research psychologist, this is one of the very confusing parts of psychology, is and even kind of a barrier. If I were to recommend someone to treatment, what kind of therapist would I want to see? And that is one part, what is their training, and also kind of what is the therapy that they provide. So in terms of who provides treatment, I'm going to provide a brief overview of the general types of providers. And first we can think about psychologists. Clinical psychologists treat what we would call full-fledged disorders. These would be things found in the DSM, the things that we talked about in the prior chapters. And there's two varieties. Typically, these individuals would have a doctoral degree. That would be a PhD or something we call a PsyD. But you get clinical psychologists who tend to treat full-fledged disorders. And there's another variety called a counseling psychologist who would tend to treat more everyday adjustment problems. An everyday adjustment problem might be anxiety that perhaps does not rise to the level of a DSM diagnosis, or even it does rise to the level of a DSM diagnosis. But kind of counseling is kind of the two different flavors, clinical versus counseling. Right? Think of the words clinic. Clinic sounds like hospital, sounds more severe than counseling. And that's the general breakdown. But this is a breakdown that is very rough, and there are clinical psychologists who do treat everyday adjustment, school problems, interpersonal problems, and there's counseling psychologists who deal with DSM disorders. So this is a very rough kind of breakdown, but one that traditionally has existed. There's a lot of overlap in specialization between these two. To be a psychologist, a clinical or counseling psychologist, is going to require doctoral training. That'll take a bachelor's degree, then 5 to 7 years to get a PhD or a PsyD. The PhD model is traditionally called the scientist practitioner model, in which the individual is trained in graduate school to not only provide therapy, but assess the therapy with research to know what is effective and what is not effective. They would be akin to, say, a doctor of oncology who not only treats patients but does research on the treatments. A PSY-D degree, the PSY.D, is a relatively newer doctoral degree. It was invented in the 1980s because of the view that they really didn't need to know a whole lot of research in order to provide therapy. So the PSY-D degree kind of doesn't have that equally balanced research practitioner model and focuses more on the practitioner, the provider of services, the therapist model, and minimizes the research aspect. Another degree, which is a doctoral degree, which someone can be a clinical counseling psychologist, is called a Doctor of Education, an EDD. And that is yet another doctoral degree that would provide an individual with the opportunity to become trained in providing therapies. Traditionally, EDDs are counseling psychologists. But all of those degrees would require 5 to 7 years of graduate school and supervised therapy to be out on one's own. There's a very popular degrees, and it says you need a bachelor's degree to get there, but you also need a very good record with a bachelor's degree to get there. Not just getting a bachelor's degree isn't sufficient. Generally, there's more applicants for these doctoral programs than there are seats available. So these doctoral programs are able to choose applicants who have very high very good undergraduate records and experiences. Also, against popular belief, you don't need a bachelor's degree in psychology. Notice it doesn't say BA in psychology, it says BA. I don't know of any doctoral program that actually requires an undergraduate degree in psychology. They generally require a certain number of courses, not a whole degree. But that being said, many people take a bachelor's degree in psychology as preparation because they want to go above the minimum that's required for entry. So if a program requires 12 credits, if you have 30 credits in psychology, you're kind of over preparing. You're doing all that you can. And they tend to prefer more credits over fewer. So even though they might have a minimum, you don't need a degree, it certainly helps to have the undergraduate degree. The other reason why people might switch to psychology as their undergraduate major is the courses required by different programs vary. So what the University of Connecticut requires for psych classes in terms of credits and particular classes is going to differ from the University of Massachusetts and differ from the University of Florida. So by doing a bachelor's degree in psychology, you're much more likely to cover all of those different bases. PhD psychologists are fully able to treat a variety of disorders with therapies, but they're limited to interpersonal therapy. They generally cannot prescribe medications. There's only 2 states in the union that allow PhD psychologists to provide medications. Psychiatrists are medical doctors, and they can prescribe medications. They're medical doctors, physicians, MDs, who specialize in the diagnosis and treatment of psychological disorders. Psychiatrists go to medical school, and then in their internship is where they choose to specialize in psychological disorders. Others might decide to specialize in children. They become pediatricians. Others might choose to specialize in the stomach, and they'll become gastrointestinal doctors. So their specialization is where they do it after medical school, and they become trained to treat disorders. They tend to treat the most severe disorders that we saw in the DSM. So to be a psychiatrist, one is going to need a bachelor's degree, of course, a very good record at that, a lot of chemistry, a lot of biology, and then go to medical school for 4 years, and then have a residency for 4 years. And it's in that residency that is what really trains them to become a psychiatrist. They have to know a lot about medications because they tend to rely on medications because they're easily able to prescribe them. As such, they tend to focus on the most severe disorders. If you look back at the clips on schizophrenia that we saw in the last lecture, the individuals there tended to have MD. The doctors had MD after their names. Because it's the most severe disorders that seem to respond best to medications. When I was in your seat, in the last millennium, and you wanted to be a therapist, these were the paths. You had to become a clinical psychologist, or a counseling psychologist, or a psychiatrist. But the world has changed a lot since then, and insurance companies realized that people could receive mental health services at a more cost-effective way from individuals who had a master's degree. So now there's a variety of master's degree individuals who can provide psychotherapy. They're not able to prescribe medicines. They will often work in concert with doctoral level folks, but they can also be on their own. Among these master's level folks are clinical social workers. Clinical social workers have their master's degree, generally in MSW, Master of Social Work, and they'll get a state license, and they'll be able to provide psychotherapy. So the master's degree requires a bachelor's and then 2 to 3 years further of study before one can start providing services. Clinical social workers traditionally have worked in hospitals with psychologists or other psychiatrists, but now it's common to see these individuals allied together in their own practice. Often they'll be working with counselors. Counselors are licensed by states, which means there's varying license requirements in terms of how much supervision and what variety of degree one might have. The minimum licensing in Connecticut, it's called the LPC, Licensed Practical Counselor, and there's a variety of different paths one can take to that license. At Southern, there's marriage and family therapy leads to that license, as does the clinical mental health counselor. Both of those are graduate programs. They're master's degrees, which means a bachelor's and then 2 to 3 years. And the thing about these counseling programs is that the training is very specialized. Doctoral training tends to be a bit more generalized, but master's training tends to be much more kind of focused. So people getting a master's degree to be a therapist are going to specialize in the problems related to their setting. The individuals in Southern's Counseling Center on the second floor of Engelman Hall, they will have, if they have their LPC, their master's degree, their training is specialized to the kinds of issues that college students will have. Everyday adjustment issues, getting along with roommates, get along with other people, time management kinds of things, working with stress reduction, working with anxiety, as well as more severe things. But some more severe things, they'll work in concert with a psychologist or a psychiatrist. Marriage and family therapists are trained to work with couples and families on interpersonal issues and the stress and anxiety that can come with being in a family. There's is, to me, the confusing part. There's so many different ways to provide therapy. How does one know who to choose to if you're a consumer of services? And then if you're a student, how do you know which one it is you want to do? The thing is, if you're a student, what you should do is look into different things. Look at these different graduate programs, read their descriptions, read about the licensing requirement, and most importantly, read about the kinds of work that they do. You should not think that getting a master's degree is going to allow you to prescribe medications. You shouldn't think that a master's degree is going to let you work in a hospital. It may or may not. It depends on the particular degree and the kinds of training that you're interested in. But the bright side is, even though it might be confusing, is there's many, many paths to getting the training that it would take to help people get through difficult patches in their lives. All right, so getting to the therapies themselves. I tend to think of the therapies as belonging to a couple different general families. And one is insight therapies, commonly known sometimes as talk therapies. And these are therapies where the person who is trained, no matter what their degree that we just talked about, these are kind of therapies provided by a variety of different educational paths, people with different educational paths, where they help people by talking to them. And this is what people typically think of when they think of psychotherapy. You go to someone's office, you sit, you talk with an individual, and after some amount of time, your quality of life is improved and your problems go away. There's other therapies, but these are the kinds that people tend to think of. The goal of insight therapies, the underlying view, is that by enhancing an individual's self-knowledge, their mental health can be improved. And that's the insight. By talking things out and thinking things through, an individual will come to understand why they have an anxiety issue or what leads to their depression. And by having that knowledge, then they can take steps to make those issues not so prominent in their life, not necessarily go away, but maybe be not so prominent. The two talk therapies that we're going to discuss are psychoanalysis and person-centered therapy, which comes from a humanistic or existential background. Psychoanalysis, right? There's this term, psychoanalysis. Get the terminology right? Psychotherapy is an umbrella term. Psychoanalysis is a variety of psychotherapy. Psychoanalysis is also called psychodynamic. It comes from the work of Sigmund Freud. And if you remember, we talked about Freud, we talked about the id, the ego, the superego. That's the dynamic, those parts of our unconscious kind of arguing with each other. And then what the therapist does is analyze those things. So whether it's called psychoanalysis or psychodynamic, it's the same thing. The underlying assumption, the basic assumption of psychodynamic therapy is that an individual's problems come from the innate aggressive and sexual tendencies that are repressed during childhood. So Sigmund and his later followers believe that it's these underlying unconscious conflicts, right? There's the psychodynamic that are innate because we are born animalistic, which means we're aggressive and sexual, and those things are usually problematic in society. If one is overtly aggressive and overtly sexual, those are problems in proper society. So we learn to repress them during childhood, and that leads to problems later in life. The goal of psychodynamic therapy or psychoanalysis is to discover these unresolved unconscious conflicts related to child events that are the cause of our maladaptive behaviors. So there's the insight, right, to discover these unconscious conflicts. The therapist will work with a client to figure out what these conflicts are. So a psychoanalyst will help an individual develop insight by making the unconscious conscious. Because Freud and the underlying belief is we have problems, but we don't know what the causes of the problems are. So the insight is kind of figuring out these underlying causes. So the techniques used by psychoanalysts to do this are ways that kind of uncover this unconscious. They kind of discover the unconscious. Now, the funny thing about the unconscious is it's not conscious. We're not aware of these things. But Freudians believe that there are clues, and an astute and observant therapist can read the clues and then tell the individual what their problem is. So the way they read these clues is by free association. Free association, if you think of the game that one might play, if typically you see it on movies and TV, is the therapist says a word and the individual has to respond as quickly as possible with the first thing that pops into their mind. That's just one aspect of free association. But the idea of free association is just letting the client say whatever they want. The prompt game is a way of doing that, but the general view is in psychoanalysis is the client comes in and is just allowed to talk for 50 minutes. They're just allowed to talk and say whatever they want, and the therapist is to look for clues. To prevent the therapist from influencing the free association, they'll often sit out of view of the individual. They won't sit face to face. So the individual often will maybe lay on a couch. There is basis to that cartoon and prototypical image, and the therapist will be out of sight so as to not kind of domineer and make it a social interaction and just allow the client to say whatever they want. The therapist will be looking for themes and looking for clues in what the person chooses to talk about and how they talk about it. Another technique is dream analysis, in which a part of the free association, the client may talk about their dreams and the therapist will interpret the symbolic meaning of dreams. Freud believed that dreams were the royal road to the unconscious, and that the conflicts of the unconscious could work themselves out in dreams, that one could be aggressive or sexual in dreams because it was a safe space. It wasn't available to anyone else but the client. So by probing dreams and analyzing the dreams, Freud believed that the therapist could divine what the unconscious conflicts revolve around. Psychoanalysis is intense. It generally involves 4 to 5 sessions per week over many years. That makes it very expensive. It makes it a commitment. This is the kind of commitment athletes, college athletes, high school athletes make to their sport. And this is year round, right? This is a deep commitment to therapy. So it's not for everyone. One must have this time in their life. A session would be about an hour. You need to have the time, you need to have the money, you need to have the support to do this over such a long period of time. There is also some limited evidence of its effectiveness. I've talked about Freud. You've heard me talk about Freud, and I think Freud's ideas are probably more a product of his own mind and his times. But there is evidence that an individual listening to someone else can provide advice that helps the individual. Sometimes maybe it's just a matter of being heard, but there is some limited evidence of the effectiveness of psychodynamic therapy. The next talk therapy is person-centered or client-centered therapy, and this comes from a very, very different background than Freud. Freud's background, Freud believed that essentially humans were innately bad. Aggression and sexual were bad tendencies. Society looked down on them, so they had to be repressed, and it was embarrassing and shameful to talk about such things. and there's a darkness to Freud's view of the world. Person-centered therapy is a direct reaction to that and tends to look at the positivity of individuals. And it goes back to the therapist Carl Rogers. Carl Rogers developed this line of thinking in the late 40s and early 50s, really as a reaction to psychotherapy and the Freudians. The basic assumption of person-centered therapy is that everyone has a tendency for positive growth. Rogers talked about the strive for self-actualization, trying to better ourselves and trying to become the best person that we could be. Rather than thinking about aggression and sexual tendencies, Rogers focused on this core drive to become better. So he believed a therapist should support this growth because disorders developed from an incongruence, that this trying to be better, trying to be a better person, that ideal self came in conflict with the actual self, that one's inability to achieve that ideal self is kind of sense holding standards too high. We're not able to achieve the ideal self, so the actual self kind of feels bad and guilty and depressed about that. The goal of a person-centered therapist is to reflect back the client's own thoughts to encourage free expression and growth. Where a Freudian therapist will look for clues and tell the individual what is wrong with them, a person-centered therapy client is going to let the individual guide their own path and lead them to their own insight. And it might be an insight the person has that the client doesn't have. But Rogers believed the therapist's view was to essentially be a mirror for the client's own thoughts. And often Rogerian or client-centered, person-centered therapists will kind of say things, well, I hear you saying that you are this. Is this true? And they'll just kind of question back to the individual rather than tell them, to try and get them to focus on their own growth and their own interpretations. This is what Rogers called non-directive, right? The client, the therapist doesn't tell the client what's wrong, but encourages the client to figure out kind of what's going on their own. But the therapist isn't without insight themselves and can steer the person to the right insight. I think of this as you're playing the game hot and cold, right? You got something in a room and you want someone to find it, and you give them clues as to whether they're hot or whether they're cold. The therapist is to steer the individual to the insight rather than give it to them. And the underlying belief is that people are capable of this insight on their own. Freud didn't believe that. Freud believed you needed to have a therapist because we're unable to get to our own unconscious. The other hallmark of Rogerian therapy is kind of these ideas of how the therapist should behave. The therapist should convey a consistent message, and this is what Rogers and these therapists call congruence. Their body language should match their words. There should be a constant evenness to the message that's given to the client. Unconditional positive regard is no matter what the client says, they're treated with warmth and respect. They must always feel welcome and safe. And to Rogers, this was very important, this unconditional positive regard. They had to be regarded with respect no matter what their issues, no matter what they said. Even if they became angry in therapy, the therapist would calmly say, well, I hear you getting angry about this. Why do you think you're getting so angry? Rather than argue with the individual, just kind of accept their anger and not take it personally and reflect it back on the individual. And this required empathy, a lot of empathy, and genuine empathy. It couldn't be fake empathy. people can tell fakeness. So it was a kind of empathy that had to be genuine and true and fit in with the unconditional positive regard. Client-centered therapy has also had there's also some evidence of limited effectiveness at treating disorders. It is similar to psychoanalysis in terms of time commitment. This might be several years for this to happen, but not so much in the weekly. It might be once a week, maybe once a month, maybe twice a month. Wouldn't have to be daily for several years. But it's a very, very different way of trying to get an individual to develop insight as to what their issues are. That will end the first section of this lecture.